Good morning, everyone. Today I'll be presenting an abstract from IJN. The topic of my presentation is the outcome of COVID-19 infection post-cardiac surgery. My name is Pao Cheong Ping, and the following are the names of my team members and supervisors, which I would like to extend my thanks for their support and guidance. COVID-19 is a highly contagious airborne virus that has caused a global pandemic, and the burden on our cardiothoracic surgery department is very high. Infection and quarantine of our staff and patients is very disruptive to our service, and we are disproportionately affected compared to other departments. The challenges that we as cardiothoracic surgeons face is, number one, we need a large team of staff involved in open heart surgery, and of course we need ICU beds and a lot of resources. Patients also have multiple comorbid medical illness because they already have underlying heart disease and often other comorbidities as well. And the severity and spread of the speed of the COVID-19 infection exceeded most of our expectations. And we find that during this pandemic, most of our elective cases have been postponed, and resources such as OT time has been rationed. And we have tend to be operating on the sickest patients under the urgent OT list. So we actually reviewed our results, and we would like to report them. So this was a single center retrospective study from October 2020 till July 2021. So we looked at all cases who were diagnosed with COVID-19 either within the same admission for their surgery or 6 weeks post-discharge from surgery. We collected the data from the medical records and also phone interviews. So these are our findings. We had a total of 15 patients, and the mean age was 63.4 years. 73% of our patients were male, and 73% of our patients had chronic kidney disease. We had one patient, which is about 6.6% of the patient, who had a previous kidney transplant on multiple immunosuppressants. 26% of our patients were obese, and the average Euroscore was 2.52. The average ejection fraction of our patient was about 48. And if you look at the type of operation that we had performed, most of the patients had CABG. We had two patients going for CABG plus valve or CABG plus, the other one was a myomectomy. We had two isolated valves and two ascending aortic repairs or replacement. 3 of the patients were done under the urgent operating list. And if you look at the days between surgery and the COVID-19 diagnosis, it was actually 16.4 days. So this actually indicates to us that most of these patients, either they got a COVID after a long stay in ICU, or they were discharged and they got a COVID from the community. And when we did contact tracing for all our patients, we actually found that 5 of these patients caught the COVID-19 infection from another patient in the same ward. 2 of them got it from a family member. 4 of them got it from the community, which is outside the hospital. And another 4 of them, contact tracing was not able to verify where they got the infection from. And if we look at our patients as well, we had 8 patients with poor EF, less than 50%. So that's 53.3% of our patient group. And if we look through our data as well, we found that 10 of these patients had the infection, which we classified as a nosocomial infection, meaning that the infection happened within the hospital, within the ward. We also had 2 patients who had early infections, meaning that we had one patient who had a positive swab on POD1 and the other patient who had a positive swab on POD2. So because all of our patients had a negative pre-operative COVID PCR test, so we believe that these two patients were actually false negatives. And they actually went for the operation in the positive state, and we only found out that they were positive because their family member told us that the family member is positive. So we did a contact tracing and we swabbed these patients immediately after the surgery, and we found them to be positive. If we look further, 3 of our patients out of the 15 patients did not require admission. So they were under category 1 to 2. 3 patients were under category 3. 6 patients were under category 4. And 3 patients were in category 5. So these are the categories that were defined by the Ministry of Health, Malaysia. And if we look at the mortality rates, all the category 5 patients, which is 3 of them, all of them died. And out of the category 4 patients, 6 of them died. So the total mortality was 46.7%, which is a total of 7 patients. And if you look at the mode of death, 2 of them died of ARDS, 1 patient died of massive pulmonary embolism, 1 patient died of septic shock after a prolonged stay in hospital due to a secondary bacterial infection, and 3 patients actually died in other hospitals. And the cause of death was written as cardiopulmonary arrest. If we look at the resource utilization, 2 patients needed intubation, and 1 of them required a prolonged ventilation for 26 days before eventually succumbing. 4 patients required NIV, which is either a BiPAP or a high-flow nasal cannula, and we had a total of 7 ICU admissions. And when we look at the excess length of stay due to COVID-19, it was 20.2 days. Some of the limitations for our study was that this was a small sample size and it was retrospective in nature. This data was not randomized, obviously, and there's a recall bias. I think we found that for those of patients who died in other hospitals, the family members couldn't give a very clear history on how they died and why. And another of our limitation is that we had different treatment protocols for those who were diagnosed with COVID in the early stage of the pandemic compared to the later stage of the pandemic. None of our patients had genetic testing, and all of our patients were unvaccinated. So what we learned from this pandemic is that we learned that some of the lessons that we learned is what we started to do is we started to cohort patients by vaccination status. We encourage all our elective cases to be vaccinated. And we are also starting to do a saliva antigen test to supplement the PCR test before the surgery. And of course, last but not least, strict infection control adherence. Thank you very much.